Welcome to the Heart Valve Society interview series. In this series, we'll connect with experts in our field to discuss fascinating topics and share valuable insights. Before I dive in, I'd like to remind that Heart Valve Society memberships offers a host of exciting benefits and opportunities. Be sure to visit the Heart Valve Society website to learn more about how you can join and get involved. We are also thrilled to announce that the next annual meeting of the Heart Valve Society will take place April 15th through 18, 2026 in Chicago, Illinois. More information will be shared soon. Now it is my pleasure to introduce, I guess myself and of course the other guests for today. And perhaps Jessica, you would like to start with that.
Yeah, thank you, Hanneke. So it's really our pleasure to be there today. We're going to discuss about women's heart disease. I'm Jessica Forcillo. I'm a cardiac surgeon at the University of Montreal Hospital Center. I'm a researcher and I'm a co-founder of Women's Cardiovascular Integrated Heart Center here in Montreal, as well as the privilege of serving on the board of the Heart Valve Society.
Thank you, Jessica. Well, my name is Hanneke Takkenberg. I am a professor of clinical decision-making in cardiothoracic interventions at Erasmus University Medical Center in Rotterdam, the Netherlands. I was trained as a medical doctor and am a clinical epidemiologist. And I'm a past president of Heart Valve Society and currently a senior, very senior advisor. Um, well, let's get started. We are a society that is involved in many aspects of valvular heart disease, such as basic research, clinical imaging, detection, prognostic tools, AI, bioengineering, pharmaceuticals, and many other important topics. In all these aspects, we should consider, of course, sex and gender-based differences, as there still exist inequities in the treatment of valvular heart disease in the world, and women are affected more by negative outcomes and survival. So to get started, Jessica, what is the current situation?
Thank you, Annika. So, as everybody knows, female remain an independent predictor of postoperative mortality and morbidities after cardiac surgery or after any cardiovascular event. Also, women living with valvular conditions have worse survival than their male counterparts. And as you know, cardiovascular disease is the first cause of mortality worldwide. There was a decrease rate since 2017, but still with an excess in mortality, despite the fact that it decreased in excess mortality for women's mortality. And surprisingly, during those years, there's an increased rate in the US and in Canada since the last 10 years in terms of overall cardiovascular mortality, but especially in women between 35 and 55 years of age. So it is very worrisome. The first cause of cardiovascular disease, death, in fact, in women is rheumatic heart disease, followed by ischemic heart disease, stroke, hypertensive heart disease, and non-rheumatic heart valve disease. The prevalence of rheumatic heart disease remains high in some regions of the world, and young women of childbearing age are disproportionately affected. Although age-standardized cardiovascular disease mortality in women has declined globally in the past 30 years, most of this decline was seen in countries with high social-demographic index. So definitely there still persist inequities across the world.
Well, it sounds like a major burden. And I guess we come to realize more and more that the impact of this inequity in cardiovascular care for women compared to men is affecting not only the women's lives, but also our society and economy. And before we dig into that, I would like to ask you the question, so what are the actual problematics for the excess mortality in women?
Yeah, there's a very interesting paper, so the Lancet Commission paper, that summarized the existing evidence and identifies knowledge gaps in research, prevention, treatment, and access to care for women. And many factors contribute to inequity between men and women in the detection of management of cardiovascular disease. Women have been underrepresented in or excluded from cardiovascular clinical trials, which has reduced the ability to measure the safety and efficacy of therapies for women, the potential for identifying sex-specific difference in important outcomes, because we know that women have different life trajectory than men, and the development of sex-specific strategies that could lead to improved guideline recommendation for the prevention and management of cardiovascular disease. And although the overall awareness about cardiovascular disease in women has increased during the past decade, most healthcare providers and patients still tend to underestimate the cardiovascular risk in women. And if I can add, women are more likely than men to be subject to health disparity that arise from social cultural factors and socioeconomic and political contexts. For instance, gender discrimination, socioeconomic burden, and constraint on physical mobility often limit women's access to optimal healthcare in general and to cardiovascular disease care in particular. So basically, importantly, the biological difference in and underlying sex-specific pathophysiology of cardiovascular disease in women have not been well elucidated, and further research is urgently needed to inform strategy for the prevention and treatment of cardiovascular disease in women. Because how come it took so long for that is because before, women's health was defined by the bikini approach, which is the breast and the reproductive system. But definitely with the excess morbidity and mortality, it's not just that anymore. And we should focus on those issues and in order to close the gaps.
Yeah, well, I completely agree with you. And I think my eyes were opened last year when the World Economic Forum report came out and taught us the tremendous, the $1 trillion economic impact that the health gap between men and women is causing worldwide, and is not only making women's life more miserable, but is also bad for economy and society. And coincidentally, in April, at our last Heart Valve Society meeting, there was a young doctor, Dr. Susie Kotit, from Aswan, Egypt, who is studying rheumatic heart disease in women. And I thought her example was really heartbreaking. Women with rheumatic heart disease, young girls, they do not want to have surgery, because as soon as you have a surgery, you have a scar, and that means that you will never get married. It's these type of factors that are also influencing the care. Mm-hmm. And I think education is important there as well. Of course, patient education, but also educations of professionals, making people realize that women are not just a bikini, as you say, and not just a heart, but are a woman with all kinds of biological interacting systems. Yeah. And that require a holistic approach, but also from a gender perspective, knowing what the social impact is of this health gap on women is so important. So thank you for that. And perhaps now I would like to ask you another question. So can you tell us what's the difference between women's and men's hearts? And I'm often asked, do women actually have a broken heart every now and then? And is it so different from men? I'm really interested to learn your perspective on that.
Yeah, microscopically, like it's the same, but the difference are more important during pathological condition. And that's where we see the difference in outcomes in men and women. In terms of the smaller anthropometric, the estrogen, the iron inflammation, and the risk factor clusterings, we can see those difference. In terms of valvular disease, for example, we're more challenged as surgeons when we operate on a woman because they have a smaller annulus, aortic annulus, for example, smaller ventricular cavity. So in terms of the vascular structure, smaller ventricular chamber, lower diastolic compliance, increase LV thickness in concentric rather than eccentric remodeling, and hence increasing ejection fraction with aging. So we're confronted anatomically to some of the differences that make the surgery more challenging. In terms of cardiac metabolism and vascular dysfunction, there's also differences in terms also of coronary microvascular dysfunction, pulmonary vascular reactivity, and remodelings. And after you have all the other pathophysiology that are different, for example, a patient presents with a myocardial infarction, it's not the usual, sometimes the usual presentation of a plaque obstructing a vessel and an obstructive coronary artery disease, but they have their own pathophysiology, such as a myocardial infarction without obstructive coronary disease, such as Minoka, Inoka. They have a lot of microvascular dysfunction, as well as, like you said, the broken heart syndrome with the Takotsubo, and the coronary dissection or the vasospastic angina. So there's still a lot of other presentations that are well known in terms of ischemic heart disease that still need to be addressed and better understand. And it's not true that with this different pathophysiology that we can definitely treat those patients the same way that we treat obstructive coronary artery disease. So there's a lot of research that needs to be done also in that aspect of the treatment of these pathologies.
No, yeah, yes, and if I can add to that, we found out in a big consortium project here in the Netherlands that actually started because I found out, and it was in patients with thoracic aortic aneurysm. I found out that in our own data set in the Erasmus MC, that the timing of surgery was delayed in women. They were operated on average at 55 millimeters, while men were operated at 50 millimeters. Well, you would think it would be the other way around. And that started a big journey into better understanding the differences between men and women in thoracic aortic aneurysm. And it's most likely a combination of sex factors and gender factors. One of the things we found by looking more carefully is we see, for example, the location of the aneurysm is in men more often in the sinus, and in women more often in the tubular part of the aorta. And when it's in the tubular part of the aorta, especially older women present way later, but also progress way faster. So this is important information that can prevent complications like dissections and aortic rupture, which we also saw 3.4 times more often in women. So this is really life and death. So I couldn't agree with you more. Yeah. There's differences and we need to address them. And then we haven't even talked about menopause.
Yeah.
Because I heard you talk about women between the ages of 45 and 55. Well, that's exactly the phase where menopause also plays a role, and we know so little.
Yeah, there's definitely like the menopause, the premenopause, and also the fertility treatment now that are more and more used. So definitely, are they associated with the incidence of cardiovascular disease? So that needs to be studied as well. And like you said, Hanneke, for sure, there's the late presentation of the patient, the underdiagnosis, the symptoms that are different. But also there's the different risk factors across the lifespan. So basically what I call like the non-traditional risk factors. So like you said, the fertility treatment, the menopause, the hormonotherapy, the complication from pregnancy with the preeclampsia, with the gestational diabetes that are precursor of having those risk factors in the future. So should these patients be followed a little bit better, or could we prevent the development of further like hypertension in the future or diabetes in the future? Because we know that for the same risk factors, the women are more affected than men. And also that if you, for example, you suffer from hypertension during pregnancy, you're 4 times more likely to develop hypertension later in life. And there's also twice as likely to have a heart attack. So this is also very interesting. And the other thing that you said, it's just, for example, for valvular heart disease or for thoracic aortic aneurysm. So we have the same diameters or same criteria to intervene in women and in men, while we should definitely be indexing as well. So should we intervene earlier in women because they are smaller BSA, or just and should we change the guidelines in that sense to be a little bit more aggressive in women as well?
Yeah, there's a lot of discussion about that. And I do believe that these discussions are also often gendered. It's very hard to make our colleagues take a different approach, take a different look at the challenges that we have. And basically, I do believe that if we would then, for example, index or do any other tailored treatment, this would benefit both women and men in the end. It will make treatment better for all. That's what I'm trying to advertise anyway. So, yeah.
And I have a question for you, Hanneke. So
Yeah.
you're very, very involved, and I know that it's a topic, women's health is a topic close to your heart. So what are the initiatives that you're currently doing in that field?
Yeah, and I'd like to learn more about your initiative, because what we did here in Rotterdam is we have started the Netherlands Women's Health Research and Innovation Center on International Women's Day. And the reason for starting it was basically the World Economic Forum report. That made us realize a few women, or a lot of women by now, and some of the men in Erasmus MC have joined us, made us realize that we need to approach women's health, including cardiovascular health, in a more holistic way. We found out that, for example, we hardly register in our electronic patient records any female-specific factors. So that means no knowledge is developing on that. And these may be different factors. For example, of course, menstrual pattern is registered with the gynecologist, but in the other specialties, hardly ever it is being recorded in a way that we can use for research as well. And we've come to realize that there is a lot of unknowns in unknown risk factors that determine women's health and disease. So we need to take these into account. So all across the Erasmus MC, specialties and researchers across all departments have joined. All of those who are focused in any type of women's health research, from cell biology all the way to population epidemiology, all the medical specialties are now connected on women's health. And what we do is, by connecting, we come to realize that, hey, indeed, if you have preeclampsia, you need to go into a prevention program at the cardiologist. Beforehand, people were not likely to talk with each other, the experts in our house. Same for research. We're now connecting basic research with clinical research, with innovators in the Netherlands who actually bring products on the market for women. And you can think of a lot of different applications, especially related to menopause. Look at atrial fibrillation and menopause. What's a normal blood pressure for women in menopause? Do we know? No, we don't. So these are some of the examples that we do. And we focus on research and innovation, and we have not started a women's clinic yet. What we attempted to do is to start an outpatient clinic for our employees who are in menopause. And within 1 month, we had a 3-year waiting list, just to show you what the impact is. So this is what we have started, and it's really taking off here. In the Netherlands, other university medical centers are joining. In Europe, the European Commission is planning to invest in this. And so I think we're going to be really big pretty soon and have a network of centers that collaborate in a holistic way on women's health. One of our spearheads is cardiovascular disease, because it's one of the chronic diseases we need to tackle.
Yeah.
So, but you've been doing some great stuff as well. That's what I heard.
Yeah, we opened an integrated women's cardiovascular health center in Montreal in 2021. So basically, our delivery care model is so we have the clinic with the pathophysiology, with the disease that are specific to women. So the one that I mentioned a little bit earlier. And after we have the research aspect, so basically we have cohort of patient with non-traditional risk factors that we follow over time, and we test new biomarkers. So we have biomarkers related to non-obstructive coronary disease, obstructive coronary disease, and as well as valvular heart disease, that we see if there is a plus value as a predictive, if it has a predictive value in that term, in terms of the disease, and to predicting also and the incidence of cardiovascular disease. We try, like you, to find innovative approach to reach on women, because we know that after pregnancy, for example, in different other communities, it's difficult for women to come to the hospital, or they lose a lot. The compliance to their follow-up is really is less than for men, for example. So we develop a model of proximity medicines in the pharmacy. So we're in the Shoppers Drug Mart, and basically the patient go there, so they don't have to go to the hospital, and we have virtual clinic with nurse practitioner that can follow these patients. For example, the patient who got gestational diabetes or preeclampsia, and they don't have time for the follow-up after at the hospital. So we do that with the pharmacy and the pharmacist. So I think that this I've shown that I've increased compliance. So it's new, like innovative way of treating women, but in the community. And we have also like academic, so we do symposium every year for health professional, and we do a lot of awareness campaign as well for the public, and we try to include innovation in that. So we have all those new trials that specifically study women, so the RIA trial, the SMART trial, the different technologies. So we try to be sensitive to that and to see how we could best serve women. So I think it's more and more important, because as you know, like before, like women represent approximately 30% of the patient in those major cardiovascular clinical trials. So we try to find ways to involve women in clinical trials and in our projects. So I think it has a plus value, and we see more and more patient every year. So there's definitely a need to have Women's Cardiovascular Health Center.
Yeah, absolutely. Yeah. And I love that, because my direct colleague with whom I founded the center in Rotterdam, she's actually doing studies into how you can attract more women to participate in clinical trials. She got funding from that from Dutch Heart Foundation. And so we should work together on that.
Yeah, the
Really,
important thing is not to work in silo. So basically,
yeah.
we have to bring our effort together, and like to close that knowledge gaps like very rapidly, because and it's all over the world. So it's not only valvular heart disease, non-rheumatic, it's rheumatic disease. So a lot needs to be done, and that's what it said in the Lancet Commission as well. So
Yeah, no, I agree. And raising awareness in a positive way. Because I spoke a bit about gendered resistance in our communities. I think it would be good to also raise awareness of that it can be positive for the entire care system if we focus on closing this health gap in women. So
yeah.
you know that perhaps that I'm writing a book, right? I'm editing a book right now, which has on cardiovascular diseases in women with a global perspective. I do that together with Majid Salmazi from the UK, from London, and also Professor Yacoub, of course, who is one of the founding fathers of Heart Valve Society, is involved. And well, I hope you want to join the book as well. Perhaps we should write something about these innovations.
Yeah.
So what do we need to change care? How do we need to change care to make it more effective for everybody, including, of course, heart valve disease patients?
Absolutely.
Yeah, and then late April next year, way after Heart Valve Society meeting in Chicago, we are planning to host the first conference, international conference on cardiovascular health and disease in women. So I think that will also raise awareness.
Yep.
And the question then, I'm also looking at the time, is where do we go from here? What should we do as Heart Valve Society? What do you think?
Yeah, I think it's important for society to be involved in that, and we see it now, like in different conference that we go. There's always sessions on women's cardiovascular disease, so it's very very encouraging. But I think that the recommendation for society is like we have to close the knowledge gaps. We had, like you said, to enhance awareness of cardiovascular disease in women. We have to target well-established sex-specific under-recognized risk factors. We need to strengthen the healthcare systems and engage healthcare professionals. And we need definitely, like you do, assess new technologies that could benefit women more, change surgical technique, bring innovation, earlier intervention, earlier detection. So there's a lot of work to do.
Yeah. Well, I couldn't agree more. And these are beautiful words to end this interview with. I'm now looking at our spectators. Thank you for joining us. And in this installment in the Heart Valve Society interview series, we hope you found the discussion, well, I did, as engaging and informative as we did. And stay tuned for more interviews in this series. We look forward to connecting with you again soon. Until next time.